Good evening, everyone, and welcome back to our Breaking Down Barriers to Care webinar series and the continuation on the topic of treating patients with cancer. Tonight, Dr. Hamilton will be reviewing the dental provider's role in management of head and neck cancer. My name is Corinne, and I am happy to be back with everyone tonight as your moderator. We highly encourage questions throughout the webinar. No question is a bad question, so please ask them in the Q&A section. All right, we're glad to have you, Dr. Hamilton, and looking forward to your presentation. I'll pass it on over to you.
Great, thanks very much, Corinne. Good evening, everyone. Thank you for joining tonight as we talk about the management of head and neck cancer. Thank you to Henry Schein for having me. I'm James Hamilton. I'm currently an assistant professor in the Department of Otolaryngology at the Emory University School of Medicine. I did both medical school and my ENT training at Thomas Jefferson University in Philadelphia. And following residency, I came to Atlanta for fellowship in head and neck oncology and reconstruction. After fellowship, I stayed on with Emory, and I currently practice at Grady Memorial Hospital in downtown Atlanta. And here at Grady, we take care of some of the city's most underserved patients. And as such, we treat a good deal of advanced malignancies of the head and neck. I've received a financial contribution from Henry Schein Dental for this webinar, but I have no further disclosures. And as a brief disclaimer, there will be some graphic intraoperative photos just as a heads up. So head and neck cancer and its treatment can lead to devastating cosmetic and functional defects with resultant psychological, physical, and nutritional detriments. The best results in terms of survival and quality of life are achieved through a multi-disciplinary approach, beginning with prevention and early recognition and diagnosis, a role for which primary providers in the medical and dental setting are ideally positioned. And this is followed by prompt referral, guideline-driven therapy, and consistent follow-up. So what I'd like to do tonight is give an overview of the basic principles of head and neck cancer management. We'll look at current demographics, as well as the intraoral and extraoral presentations of disease. We'll talk about the indications for oncologic referral and the surgical approaches to ablation and reconstruction. When we talk about head and neck cancer, we're referring to a heterogeneous group of malignant tumors, all of which arise in the upper aerodigestive tract. For our purposes tonight, we'll look mostly at the oral cavity and oropharynx, but it also includes the hypopharynx and larynx, nasopharynx, paranasal sinuses, and salivary glands, as well as diseases of the thyroid and cutaneous malignancies of the face, scalp, and neck. It's important to note that the oral cavity and oropharynx can experience both cancer itself and the effects of cancer therapy when adjacent anatomic areas are treated. It's the seventh most common cancer worldwide. In 2018, accounted for 600,000 new cases and more than 300,000 deaths. By and large, we're talking about squamous cell carcinoma, which occurs in the mucosal lining of the mouth and throat and accounts for over 90% of these tumors. The remainder are made up of sarcomas, lymphomas, salivary gland tumors, and lesser seen entities such as mucosal melanoma, verrucous carcinoma, and various adenocarcinomas. In the United States, head and neck cancer accounts for about 3% of all new cancer cases and 1.8% of cancer deaths. In 2022, we'll see about 54,000 new diagnoses in this country, and more than 11,000 people will succumb to the disease. Who ultimately dies from this is heavily dependent on when they are diagnosed, with patients who are diagnosed early at stage 1 or stage 2 enjoying a 5-year overall survival of almost 90%. Which drops off precipitously in those diagnosed at stage 3 or stage 4, who have a 5-year overall survival rate of worse than half at about 45%. And this is important because 2/3 of head and neck cancer patients still present with advanced stage disease, defined by either a large primary tumor or metastasis to the cervical lymph nodes. Distant metastasis is catastrophic, but still fairly uncommon at diagnosis, seen in fewer than 10% of patients. When we look at survival, for all stages combined, about 85% of patients will survive the first year after diagnosis. 5-year overall survival rate is about 65%, and at 10 years out, a little better than half the patients are still alive. When we stratify by stage at diagnosis, the 5-year survival for patients diagnosed with localized disease, limited to tumor at the primary site, is about 85%. With regional metastasis to the cervical lymph nodes, it drops to about 65%. And when distant metastasis is present at diagnosis, survival drops to a pretty terrible 39%. The median age of diagnosis is 62, and across all anatomic subtypes, there's a male to female preponderance of 2 to 4 to 1. Over the past 20 years, cancers in the oral cavity and larynx have decreased, with a decrease in tobacco use in the developed world. At the same time, cancers in the oropharynx, that is the tonsils and base of tongue, has increased with an increase in the prevalence of infection with the human papilloma virus. When we look at risk factors for head and neck cancer, tobacco remains responsible for 75% of all new cases. Active smokers have somewhere between 5 and 25 times the risk as non-smokers. And this is dose dependent, both on duration and quantity, with significant increases in incidence in patients who smoke for more than 20 years and in those who smoke more than 20 cigarettes per day. Smokeless tobacco, still frequently seen in some parts of the country, less so in others, is another high-risk behavior that puts users at 2 to 4 times the risk of oral cancers. And these elevated risks are modifiable. They decline slowly with cessation of tobacco products. And after about 10 years, the risks of former smokers have been shown to approach those of non-smokers. Independently, alcohol use is a risk factor that doubles the risk of developing cancers in long-term heavy users. By most accounts, high-risk drinking in men is more than 4 drinks per day or 14 in a week, and slightly less for women at 3 per day or 7 per week. More importantly, the concurrent use of tobacco has a synergistic effect and accounts for a 30-fold increase in malignancy when used together long-term with alcohol. Worldwide, betel nuts and areca nuts, which are chewed in various formats, often mixed with tobacco, account for a 2 to 15-fold increase in the incidence. And this is mostly seen in Southeastern Asian populations, both worldwide and here in the United States. Other factors which have been implicated but less studied are the presence of untreated reflux, poor oral hygiene. Patients with HIV or other immunosuppressive disorders are not only at increased risk, but they face worse outcomes and have increased recurrence compared to other patients. Diets high in animal fats and low in fruits and vegetables has also been implicated, but there's not too much literature that's convincing. The most recent impactful causal factor for head and neck cancer is human papillomavirus. HPV is a group of about 150 related viruses, of which 40 can be spread by contact. And these are generally transmitted through sexual activity. It's estimated that about 90% of Americans are exposed in this manner, and it's at some point in their lives. The virus-related induction of cancer, however, is attributed to just a few subtypes, with HPV 16 and 18 being the most high risk and also associated with cervical and anogenital cancers. This happens through a still incompletely understood process. We know that most people clear the infection spontaneously. However, somewhere around 30% of people will harbor a chronic infection with HPV hiding out in the tissues of the lingual and palatine tonsils. In about 10% of these folks, the virus will integrate with the host DNA, which results in the production of viral oncoproteins, E6 and E7, which inactivate tumor suppressor genes. In about 1 to 4% of these patients, at some point, usually decades later, a trigger transforms that chronic infection of the tonsillar tissue into an invasive tumor. And this latency period can be anywhere from 10 to 30 years after exposure, which is important to let patients know. In diagnosing these, I've been party to some uncomfortable conversations surrounding this diagnosis when the method of transmission comes up, but it's by no means a recent event. But it is on the rise. The presence of HPV in oropharyngeal cancers has risen from about 40% prior to the year 2000 to about 3/4 of all new cases diagnosed since 2005. We've learned that the presence of HPV is an independent prognostic factor for survival. In one of the largest early studies shown here from 2010, published in the New England Journal of Medicine, with HPV-driven oropharyngeal cancer, the overall survival of patients with virus-related tumors was 25% better than their HPV-negative counterparts. Progression-free survival was even better, with 72% of HPV disease alive and disease-free at 5 years, compared with 43% of the HPV-negative patients. This accounted for a 58% reduction in the risk of death from disease. They also noted, however, that persistent smoking, even in HPV disease, reduces this benefit somewhat, and they noted that the risk of death was significantly increased with each year of continued smoking. As a result of this development, the new presentation of head and neck cancer is a younger patient, most often male, with a latent HPV infection, as opposed to your traditional heavy smoker or heavy drinkers. HPV head and neck cancers present with smaller tumors. They can often be difficult to detect on exam, and frequently large neck masses that are attributed to some other cause, which leads to the aforementioned delay in diagnosis and ultimately treatment. Despite the improved survival of patients with HPV-driven disease, overall outcomes in patients treated for head and neck cancer have not improved substantially over the past 30 years. So the simplest and best hope for better results is de-escalating disease at the stage of diagnosis. We need to get better at catching these cancers early. And this pans out in the literature. Most studies report 3 to 6 month delays in diagnosis, which leads to advanced tumor stage and portends worse prognosis in these patients. Delays as little as 60 days have been associated with worse functional outcomes regarding speech and swallowing, which leads to lower quality of life, but also with increased recurrence, which leads to increased mortality from disease. When we look at why this occurs, we find that lack of awareness among patients is the primary driver of prolonged time to presentation. Until the disease is quite advanced, there are a lack of specific clinical signs, particularly among those patients with HPV-positive disease, that drive patients to seek care. Even large lesions remain asymptomatic, and they can frequently be ignored or are misattributed to other causes. Additionally, lack of practitioner awareness is also a contributor. Many patients who present with symptoms are frequently treated with several rounds of antibiotics. They often get bounced from ED to ED or urgent care center before the diagnosis is suspected and the appropriate referral is made. While these delays are ongoing, the natural history of head and neck cancer is development in a stepwise fashion. This illustration is the molecular progression model of multi-step carcinogenesis that's been implicated in the transformation from normal mucosa to squamous cell cancers. Within the normal mucosa, dysplasia can develop after prolonged carcinogenic exposure. Mutations occur that cause loss of heterozygosity, first at chromosome 9, followed by 3 and 17 in a predictable fashion, which leads to the inactivation of tumor suppressor genes. Once this happens, it paves the way for further genetic losses, which allow for a steady progression from dysplasia to carcinoma in situ, and ultimately to an invasive cancer. So let's take a look at where this occurs. Anatomically, the oral cavity and oropharynx are separate regions. They border each other, but they don't overlap. The distinct anatomic borders that separate the two sites from above are the junction of the hard palate and soft palate, which is the posterior reach of the oral cavity, and from below the circumvalent papilla, which is the anterior-most extent of the base of tongue or lingual tonsil in the oropharynx. Current evidence supports the fact that tumors at these two sites are distinct and unique and differ in etiology, pathogenesis, prognosis, and treatment. And as such, it's important to accurately describe these locations to guide the final diagnosis and ultimately the appropriate treatment. Current standard for detection of malignancies or potential malignancies is visual inspection and a complete head and neck exam. Performing the extraoral and intraoral exam is typically fast, it's straightforward and painless, and it should be carried out as part of any routine clinical oral exam. It's recommended that providers develop a consistent method and perform the exam in the same order so as not to omit any of the crucial areas. I tend to prefer the method shown here, which starts extraorally with palpation of the neck for concerning lumps or bumps. It could be lymph nodes. From there, working anterior to posterior, the lips, buccal surfaces, and gingiva should be exposed and examined. The tongue, floor, mouth, and hard palate should be evaluated both visually and manually, taking note of any abnormal textures or sensations noted by the patient. And finally, with adequate light, the soft palate and anterior oropharynx can be seen and evaluated, although it's tough for palpation in most patients due to a gag reflex. It is important to let patients know clearly that cancer screening is being done. This allows them to ask questions and especially counsel them on the reduction of risky behaviors. Despite data from trials in breast, cervix, and colon cancers that have shown cancer screenings can prevent the development of cancer at these sites and decrease site-specific mortality, we have no similar studies among head and neck patients that provide evidence to support routine oral cancer screenings. This has resulted in a lack of formal recommendations to advocate for routine screening by government regulatory bodies, including here in the United States. This is a 2014 statement by the United States Preventative Services Task Force, in which they concluded that there is insufficient evidence to determine any benefit and could not recommend routine screening by primary care providers. Despite the lack of strong evidence to support the examination of all patients in the clinical setting, these exams are cheap, quick, and they remain bolstered by the fact that early diagnosis has improved survival. The American Head and Neck Society, while acknowledging the lack of evidence, officially responded that these exams, especially in at-risk patients, may decrease the morbidity and mortality of disease, and formally advocates for routine screening. Likewise, the American Dental Association and the American Academy of Oral Medicine make similar recommendations for exams to be performed as standard of care. So how do these patients typically present? Within the oral cavity, which is the most common site of cancers in the head and neck, lesions can be detected at any of the identified subsites, most commonly on the oral tongue and in the floor of mouth, which account for 75% of cases. But they're also seen on the lips, alveolar ridge of both the mandible and the maxilla, buccal mucosa, the hard palate, and the retromolar triangle. The presentation is variable, and symptoms, when present, are often related to the primary tumor. These lesions can, however, be painless and asymptomatic, even as they grow large, and it's not uncommon for patients to present only after the development of severe signs or symptoms. And by that time, they're usually at an advanced stage, where they present with an aggressive lesion, which is unmistakable. They're defined by indistinct borders, a central ulceration that may bleed, and exophytic patterns, which have these things almost blossoming out of the mouth, or endophytic growth patterns, which appear somewhat subtle, but on palpation can feel deeply invade the tongue, deep intrinsic and extrinsic musculature, as well as the floor of mouth. Oral cancers occur most frequently in your smoker drinkers. They're often older and appear older than their stated age. Frequently, they're cachectic, or they've experienced a degree of unintentional weight loss. They're most often very aware of their tumors, or at least that there's some sort of problem in the mouth. They'll complain of oral pain, or less frequently, but numbness can be a symptom. Sometimes they're a bleeding or ulcerated lesion, but other times unexplained loose teeth or just a dental prosthesis that no longer fits well is the only sign. For those lesions that you don't need a well-trained eye for, however, presentation can be more subtle. Squamous cell cancer can present with a range of mucosal changes and symptoms, and there are many different oral mucosal lesions that have an increased probability of evolving into cancer. These were previously known as potentially malignant disorders. They've been renamed by the World Health Organization as potentially premalignant oral epithelial lesions. They represent a broad spectrum of clinical presentation based on the concept of field cancerization or widely dysplastic mucosa. It's important to distinguish them from other commonly seen abnormalities like aphthous ulcers, palatine or mandibular tori, and amalgam tattoos, because the speed at which cancer develops in the mouth and throat is not uniform. And so when these are recognized, they require prompt attention, as early detection and removal may prevent malignant progression. The most common of these is oral leukoplakia. Worldwide, found in about 4% of people. It's defined officially as a white plaque of questionable risk, having excluded other diseases and disorders that have no known risk for cancer. There's no specific histopathologic features that define leukoplakia. It's the presence or absence and the degree of dysplasia that determines its likelihood to progress. Recently, a meta-analysis of 32 studies involving almost 24,000 patients was published, and they described a mean malignant transformation rate of 9.7%, which was considerably higher than the previously noted rates, somewhere between 1 and 3%. They noted that progression was primarily driven by dysplasia. However, other risk factors were brought to light, including a non-homogeneous appearance of the lesion, female sex, age greater than 50, and in those lesions that are present on the ventral tongue and floor of mouth. Lesions larger than 2 centimeters were also known to be higher risk. Erythroplakia, defined as a fiery red patch, that can't be characterized clinically or pathologically as any other definable disease, presents as painless, well-demarcated flat red lesions anywhere in the oral cavity. It's much less commonly seen than leukoplakia, but is much more concerning for cancers. It can stand alone, or it can often be intermixed in a white and red pattern known as erythroleukoplakia. And most sources quote a rate of malignant transformation between 45 and 65%. However, more recent literature has cited rates as high as 90%, and many clinicians often consider erythroplakia to be the first clinical sign of the development of squamous cell cancer. Less risky, but still concerning, oral lichen planus is a mucocutaneous inflammatory disorder. The pathophysiology is currently understood as T-cell mediated autoimmune destruction of the basal epithelium. On presentation, they're white lesions on a red or erythematous base. The most characteristic feature are those white lines you see in the bottom image, most frequently on the buccal mucosa, known as Wickham striae, which have been said to be pathognomonic for the condition. Unlike leukoplakia and erythroplakia, patients will often complain of pain or burning at the site of these lesions, and they have a malignant transformation rate of about 1.4% per year. Again, the risk is increased when they're on the tongue, in females, and then in those patients who use tobacco and alcohol, as well as folks diagnosed with hepatitis C. There are other less common presentations of oral cancer, which include mucosal ulceration without the characteristic red or white changes, as seen on the top right. Non-healing extraction sites can also harbor squamous cell cancer, especially when they progress for longer than 6 weeks. And finally, cystic lesions, often discovered incidentally that surround teeth during other workups, can harbor cancers. In contrast, patients with oropharynx cancer, they tend to be younger, often non or never smokers and infrequent drinkers. They appear otherwise healthy and are highly functional. More attention has been drawn to this disease as we're seeing celebrities being diagnosed. Both Michael Douglas and Stanley Tucci have been forthcoming about their recent diagnosis and treatment, which has raised awareness of this risk. These patients frequently present with only a neck mass, and if any intraoral lesion, it's subtle or even undetectable at the back of the mouth. They're most often not symptomatic. They have no problems eating, speaking, or breathing, and these are usually incidental discoveries. They happen in the oropharynx, whose anatomy is shown here. It's defined by an abundance of lymphoid tissue, including the lingual tonsil at the base of tongue and bilateral palatine tonsils. Together with the adenoids superiorly, these structures form a ring of lymphoid tissue where these tumors like to hide out. The soft palate, uvula, and posterior pharyngeal wall are also part of the oropharynx, so it's less common to see squamous tumors originate at these sites, and they're more often the site of spread. Like the oral cavity, these tumors are varied in presentation, though more commonly they're smaller in size, and they're far less frequently the cause of patients' discomfort. Most often they need to get fairly large before patients develop any sort of symptoms. Even with that tumor on the bottom right, which is not subtle, symptoms were quite mild. This was an older lady, and her only complaint was a mild sore throat. She was still tolerating a full diet. Far more commonly, cancers of the oropharynx will be identified by the presence of a neck mass. These appear suddenly as firm, painless lumps or bumps in the lateral neck. They're often noted while patients are shaving or pointed out to others by others. They're easily palpated, and they generally aren't too bothersome to the patient, but to the provider, they should raise an immediate red flag. Any neck mass in an adult should be considered cancer until proven otherwise. Too often, these are the patients who don't get better after seeing several different providers and completing several courses of antibiotics, only to have their diagnosis delayed by months. To make this diagnosis, any concerning lesion should prompt a complete history, noting the onset and duration of the lesion, as well as direct questioning about any associated symptoms. Patients with radiating ear pain often have oropharyngeal lesions, and the pain's present even before they're clinically detectable. Likewise, pain or difficulty swallowing may preclude any notable abnormality of the mucosa anywhere in the oral cavity or oropharynx. The presence of trismus or dysarthria can be suggestive of deeper invasion into the tongue and the muscles of mastication that may not be immediately evident when you look at the lesion through the mouth. Patients should be asked about comorbid conditions, and they should be documented, and risk factors should be identified, and patients should be counseled regarding the reduction of risky behaviors. Any patient with a potentially malignant lesion that does not resolve within 2 weeks should undergo a complete head and neck oncologic screening, including a prompt biopsy. Tissue sampling is the gold standard in diagnosing dysplasia and invasion, and it comes in 2 forms, excisional and incisional. Excisional biopsy excises the entire lesion, and it can be both diagnostic and therapeutic, but it can also lead to problems when invasive malignancies are incompletely excised. I generally like to avoid excisional biopsies unless the lesion appears overwhelmingly benign or is small enough that I can take it with a 1 centimeter margin without causing functional or cosmetic deformity, which is uncommon. Incisional biopsies are preferred as it leaves the tumor in situ, and in case of malignancies When they're found, it facilitates identification of the primary on further treatment. Additionally, even small cancers may spread early to the cervical lymph nodes, which necessitates further surgical management and obviates the need for any extensive resections in clinic. The technique for incisional biopsy is fairly straightforward. It's illustrated here. To maximize the ability of the pathologist to make the diagnosis accurately, the most representative part of the lesion should be captured. This may require sampling several areas in non-homogeneous lesions to make sure any invasion is captured. It's also helpful to include a small cuff of healthy surrounding tissue so that the tumor interface can be evaluated. Any necrotic areas or areas of pus or fibrinous debris, which are most often found right at the center of the lesion when they're ulcerative or draining, should be avoided. Stay away from sending those because they're not helpful with the histologic diagnosis. It is important to preserve the original characteristics of the lesion to ensure that the site, dimensions, and most importantly, the margins remain identifiable. And finally, to prevent drying and deformation that can complicate the microscopic evaluation, all these samples should go straight into formalin before they're transported to the lab to keep them in the optimal condition. In addition to scalpel, you can also use a punch biopsy, which gives the pathologist a good sense of depth of invasion, though it's not definitive. Recently, a lot of non-invasive clinical diagnoses have emerged that are of potential utility. The most commonly referred, I've listed here. Toluidine blue is a dye that can be applied as an oral rinse. It preferentially stains cells with elevated nucleic acid content, as seen in dysplasia. It has been shown to have good sensitivity, but low specificity, leading to high rates of false positives, which is the problem across the board with these. Rush biopsy kits can detect cytologic changes in all layers of the epithelium, but generally only in visible oral lesions that are accessible through the mouth. Again, they suffer from low specificity, as do optical imaging systems, such as Visalite, which can detect alterations in the tissue structure, vascularity, and integrity, which may suggest abnormal metabolic changes consistent with dysplasia. However, it's not too dependable to distinguish the dysplastic lesion from the non-dysplastic lesion and remains a promising adjunct. None of these have shown a real valuable increase in the independent early cancer detection, and so they're not a substitute for biopsy, but most literature shows that they may have a role in determining which patients are candidates for a strong recommendation. Many patients are hesitant or fearful of moving forward, and evidence obtained through any of these methods may be a little helpful in pushing them toward a more formal biopsy. In those patients who present with a neck mass and no discernible oral or oropharyngeal lesion, again, any neck mass in an adult is cancer until proven otherwise, should be sampled promptly. In some settings where it may be reasonable to suspect an infectious or an inflammatory source, you can try a brief course of antibiotics, but it's important to ensure follow-up, and referral to a head and neck oncologist should be made if these lesions don't resolve in 2 weeks. These masses should always be evaluated first with fine needle aspiration. In the setting of cancer, open biopsy of cervical nodes can lead to tumor seeding in the neck and scarring that can complicate any further oncologic surgery and increase the risk of complications. In addition to fine needle aspiration, clinical exam by the oncologist must include a fiber optic endoscopic exam of the nasopharynx, oropharynx, hypopharynx, and larynx to not only localize the primary tumor, but to rule out any potential second primary. I included this clip to show you how subtle these lesions can be. This is a patient who came in with a painless neck mass that was shown on FNA to be HPV positive squame with no primary on CT. But you can see as we sweep over it, that whitish discoloration that was easily missed on physical exam and shows no radiographic presence was the only manifestation of the primary tumor and was easily missed. Following diagnosis, evaluation of masses in the head and neck requires cross-sectional imaging to complete the clinical staging of the tumor. Imaging is crucial to assess the size and depth of the lesion, the presence of any bone or muscle infiltration, as well as invasion of local structures, including nerves and blood vessels. It's also necessary to determine the presence of regional metastasis to the cervical lymph nodes, as well as any distant metastasis, most often to the lungs, to complete the workup. The available modalities offer mutually beneficial information, and it's not uncommon for combination of studies to be ordered to provide the full clinical picture. Contrast-enhanced CT is most frequently the initial study of choice. It's fast, it's cheap, it's widely available, and it's the preferred imaging modality in workups for oral cancers, especially when it comes to assessing for invasion of bone by tumors close to the mandible. It's important to note that the addition of iodine contrast is imperative to provide the enhancement required for soft tissue detail and to determine any lymph node involvement. We know that CT is better than the physical exam in detecting lymph node involvement, and it can also detect extranodal extension, which make it incredibly useful in staging nodal disease. But again, non-contrast CTs, while they're easier for the patient, are insufficient for evaluation, and they frequently need to be repeated. For that reason, I try to encourage all providers, especially here at our institution where many of these patients come in through the ED, which has a tendency toward non-contrast CTs, to ensure that these studies are ordered with contrast to not only increase the speed and accuracy of the workup, but to make it a little bit easier on the patient. MRI, so magnetic resonance imaging, is superior to CT when it comes to soft tissue detail and assessing any perineural spread, invasion of the bone marrow, and non-calcified cartilage, as in tumors spread to the larynx. For soft tissue tumors, such as those in the oral tongue, MRI can help determine the medial extent for surgical planning regarding primary resection and any need for bilateral versus unilateral neck dissection. Regarding perineural invasion, the image I have here is a stock image, but it shows the detail that MRI can provide about perineural spread. This is a right-sided oral tumor that invaded through the masticator space in the mandible. It's traveling superiorly along the inferior alveolar nerve, up through the foraminal and into the middle cranial fossa, which is important information to have on hand before you take any of these patients to the operating room so that you can have your neurosurgery friends ready. PET scans. PET scans are functional images. They're based on metabolic activity in malignant lesions. Metabolically active cells will take up radioactive tracer and light up on an image that's often laid over an anatomic CT scan. The main use here is identification of subclinical regional neck metastasis or metastasis to the lungs or beyond. It has become standard of care in the pretreatment workup of tumors in the oral cavity and oropharynx, as it can detect distant lesions as small as 5 millimeters. Secondarily, it's become very useful in patients with biopsy-proven neck metastasis and the unknown primary tumor. In these patients, in whom physical exam and often CT fail to locate a primary, they're usually in the oropharynx and they're usually HPV driven, but it can often be identified on the PET. Studies have shown that squamous cell carcinomas of the unknown primary can be determined in 30 to 40% on the first PET scan, which has become incredibly helpful in reducing the radiation field that would otherwise need to cover the entire pharynx. And in doing so, we can spare patients the morbidity of a totally radiated throat. When it comes to staging these tumors, the TNM staging, the AJCC, is the most commonly seen for both oral cavity and oropharynx and requires an assessment of the primary tumor, or T, lymph nodes, indicated by N, and M for distant metastasis. Once the imaging workup is complete, the clinician has enough information to grade the primary tumor based on the size, location, and involvement of any surrounding structures, as well as to identify the number and location of any clinically overt nodes and to assess for distant metastasis. Staging is important. Patients want to know their stage to give them a sense of their outcome, but really it's integral for treatment planning, for assessing the results of any clinical trials, and following treatment to evaluate treatment efficacy. When patients undergo surgical resection, staging is often repeated, and based on the resection specimen, information is used to guide any postoperative adjuvant therapy. In the oropharynx, as HPV cancer has become increasingly recognized as a separate disease entity with improved outcomes compared with HPV-negative disease, the most recent update to the standards has created a separate stage for oropharyngeal cancers based on HPV status. While HPV-negative cancers are treated largely the same as oral cavity, HPV-positive cancers have had both the size of the tumor and the extent of nodal disease downstaged due to a decreased impact on overall survival. Likewise, the notation of extranodal extension has been eliminated in HPV-positive disease. Staging, however, has not yet changed the recommended treatments. There are several large trials exploring de-escalated therapy for virus-driven disease that are expected to result soon, but nothing has changed officially. Regarding management, the treatment of head and neck cancer is increasingly complex. With an eye toward improving both oncologic outcome and quality of life, these patients require access to a broad spectrum of individual specialties. This is a busy diagram, but I think it illustrates well the complex network of care that head and neck cancer patients require. These needs are best met in tertiary care institutions with established multidisciplinary teams. Potentially curative therapy requires collaborative efforts of physician teams from across disciplines, as well as specialized ancillary services that provide patients with access and support from everything from clinical trials to spiritual support. Multidisciplinary tumor boards have become standard of care for the evaluation and management of patients with head and neck cancer. Input by representatives from surgery, radiation oncology, and medical oncology has been shown to be more effective at providing appropriate, individualized treatment plans, especially in the setting of disease stage where the guidelines allow treatment with different modalities rather than a single definitive option. Multidisciplinary care allows for individual treatment decisions that can weigh published guidelines against individual patient safety and comorbidities, providing a more personalized approach to cancer therapy. It's also been shown to improve outcomes. This is a study from 2019 that assessed the impact of patient presentation at a multidisciplinary tumor board prior to treatment and its effect on survival. Presentation changed the diagnosis, the stage, and/or the treatment plan in 27% of cases. And they found that both the 5-year overall survival and disease-free survival were significantly improved following the implementation of a multidisciplinary tumor board. Presentation prior to treatment decision reduced the risk of death by half in the cohort that was presented preoperatively. When we talk about treatment of the oral cavity, it can be divided into management of early stage disease, which is localized to the primary site, and late stage, which is defined by larger tumors or spread to the lymph nodes or beyond. For early stage disease in the oral cavity, surgery is the mainstay of treatment. And for later stage or more advanced disease, adjuvant therapy following surgery is preferred for resectable disease. Adjuvant therapy may be radiation alone or concurrent chemo and radiation together for high-risk disease. The choice of treatment is dictated by the pathologic findings, and oftentimes chemotherapy will be added concurrently in the setting of positive margins, advanced nodal disease, or the presence of extranodal extension, which can incur a higher risk of recurrence. Surgical resection of these oral cavity tumors can be performed via multiple techniques, all of which are founded on the same principle of complete oncologic resection with a minimum of a 1 centimeter margin. The transoral approach is usually used for premalignant lesions and small superficial tumors, like on the top left, often seen in the anterior floor mouth, alveolus, and tongue. More invasive approaches are necessary for posterior located tumors or when patients have limited access due to trismus or inadequate exposure. In the middle row, you see the lip split with a paramedian mandibulotomy, which is frequently used for big tumors or tumors located farther back, as it offers excellent exposure, but at the expense of a moderate cosmetic disadvantage. Alternatively, the visor flap, seen on the bottom left, can be created for bilateral exposure of the mandible for more extensive defects or to facilitate reconstruction. On the bottom right, we see upper cheek flaps and midfacial degloving approaches, which are useful for gaining access to the maxilla. With regard to treatment of regional mets, neck dissection has historically been performed as part of the resection, even in clinically node-negative necks. When the risk of metastasis exceeds 15%, which is frequently common, in tumors that approach the midline or have known bilateral lymphatic drainage, such as those in the floor and mouth, bilateral neck dissections are performed. And it's been done upfront to positive benefit. Inclusion of the neck in nearly all cases of surgically treated head and neck cancer has been shown to improve outcomes. And this was born out of this landmark trial from 2015 conducted in India, which compared elective neck dissection to watchful waiting in almost 600 patients with T1 or T2 disease, early stage localized disease with node negative necks. Performing neck dissection up front resulted in improved 3-year overall survival rate, as well as improved disease-free survival. Elective necks reduced the risk of death by 26%. And in fact, the trial was stopped early due to the clear benefit on survival. So let's take a look at how this is applied to real cases. This is a case of a 62-year-old non-smoker who had been followed for several years for a 1.5 centimeter oral leukoplakia. The lesion had a homogeneous low-risk appearance, and she underwent regular incisional biopsies, which ultimately returned squamous cell cancer. On imaging, there was no regional metastasis, so she underwent a transoral approach to excision with 1 centimeter margins and a right neck dissection. In final pathology, she had a T1 N0 lesion, small localized lesion with no metastasis to the neck, and she required no further treatment. On postoperative day 1, she was tolerating PO diet, and 2 years following surgery, she remains without any evidence of disease. This is an example of a more advanced case. This is a 68-year-old lifelong smoker drinker who presented with an exquisitely tender, ulcerated lesion over the left side of her oral tongue. Incisional biopsy was performed in clinic, showed an invasive squamous cell cancer, and she was worked up with an MRI, which showed that the tumor infiltrated the intrinsic tongue muscles and crossed midline. On PET scan, multiple ipsilateral nodes were seen, and she underwent a transoral approach to a hemiglossectomy. She had a bilateral neck dissection and was found to have advanced stage disease, T4A N2C, with bilateral positive nodes and extranodal extension. She underwent a free tissue reconstruction, the results of which we'll see shortly, and was recommended adjuvant chemoradiotherapy, which she completed, and at 3 years out, has no evidence of disease. When we look at floor of mouth lesions, the situation changes a little bit. This is a patient with an early stage floor of mouth cancer. He was 50 years old and he had HIV. He presented with a non-tender superficial lesion just under his tongue on the left. Biopsy showed squamous cell cancer, and CT scanning showed no nodal disease. But despite the small size of this lesion, these are high risk due to their location. The floor mouth is highly vascular, and it has a rich lymphatic network, which makes these tumors subject to early bilateral metastasis to the regional nodes. He underwent a wide local excision and a bilateral neck dissection, which fortunately showed only a superficial T1 lesion, and he had no positive lymph nodes. So he got no further treatment, but he remains under much closer surveillance than I would otherwise do, given his immunocompromised status, which leaves him at high risk for recurrence or even a second primary. His surgical defect was closed with a skin graft, an example of which is shown on the right. This facilitates surveillance rather than burying it under a flap and makes for more prompt discovery of any potential recurrence. Here's another example that shows how difficult and dangerous these floor mouth tumors can be. This is a 59-year-old who presented with 3 weeks of painful bleeding and an ulcer under his tongue. He was a pack-a-day smoker since age 12, and he drank 72 ounces of malt liquor daily. On his CT, the lesion measured about 5 centimeters and showed no mandibular invasion. He underwent wide local excision, bilateral neck dissections, and was reconstructed with a free flap. And on pathology, it invaded deeply into his tongue and floor mouth, almost to 2 centimeters, showed positive lymph nodes bilaterally, which had expanded beyond the capsule and showed extranodal extension. He underwent a full course of adjuvant chemoradiotherapy, with which he was compliant and he completed on time. 3 months following surgery, he was eating and speaking well, but at 6 months, the surveillance PET showed pulmonary metastasis, and at 9 months, he had brain mets on an MRI, and ultimately passed due to his disease a short time later. With tumors that involve the mandible, invasion occurs earlier when their tumors are located in the floor mouth, ventral tongue, and gingival buccal sulcus. When they abut the mandible on imaging but show no clear disruption of the cortex, marginal mandibulectomy is the recommended margin, which allows for pathologic exam of the periosteum. These are limited to patients with teeth, however, and in cases of close tumors in the edentulous patient, segmental mandibulectomy is the safest choice. The remaining indications for segmental mandibulectomy are gross bony invasion on cross-sectional imaging, and in those patients who on physical exam have mandible tumors that are fixed to the mandible, segmental mandibulectomy is recommended if they've had prior radiation, regardless of any findings on radiographs. An example of this is this 83-year-old patient who was a former smoker and drinker who noted a 40-pound weight loss over about 6 months and presented with this tender lesion over his left jaw. Biopsy showed squamous cell cancer, and on his CT scan, there was clear erosion of the mandibular cortex at the superior margin. To resect this, he underwent a visor approach, which spread across the anterior neck, and a composite resection of the bone and the anterior floor of mouth. His pathology showed a T4A tumor, and he underwent adjuvant radiotherapy. Following his surgery, he was able to tolerate PO diet at 2 weeks and he was pleased with the cosmetic appearance. A more extreme example is a 70-year-old smoker who had a lesion over her anterior chin and ulcerated for about a month. She had some weight loss, but her biggest complaint was numbness over her chin and lip and several missing teeth. PET scan showed erosion of the mandible bilaterally, as well as spread to lymph nodes in the bilateral neck. She underwent a composite resection, which was extensive but complete, as well as multiple free flaps to reconstruct her. Despite the advanced stage of her disease, she was stage T4A N3B with positive extranodal extension. She underwent chemoradiotherapy and was able to tolerate a diet at 2 months, was able to return to full phonation, and was pleased with the look of her new chin. Compared with treatment of the oral cavity, management of the oropharynx is more complex and controversial. For early stage cancers, current evidence supports single modality therapy with either surgery alone or radiation by itself. Treatment planning is challenging with these lesions because the functional and curative outcomes aren't always predictable. There's no evidence-driven advantage to survival, and studies have shown that dysphagia may be greater with radiation to the pharynx, as well as a return to oral diet may be better with surgery alone. However, in advanced cancers, both HPV positive and negative, these lesions typically require combinations of either surgery followed by radiation or initial concomitant chemotherapy and radiation. With these lesions, multiple trials are underway to explore de-escalation therapy, particularly in HPV disease, which look promising but have not yet changed the guidelines. So when deciding on therapy, organ preservation is preferred, especially if functional or cosmetic outcomes results in higher morbidity or lower quality of life than a non-surgical alternative. And historically, this has been the case, as access to the oropharynx was traditionally done through the previously described open approach, which required splitting both the lip and the mandible to reach the tumor. Over the past 10 to 15 years, however, the pendulum has swung back towards surgery with the advent of minimally invasive techniques, including transoral robotic surgery, or TORS. TORS allow surgeons to use a surgical robot to view and access tumors in the head and neck with no incisions through the neck, chin, or lip that were typically required in the open approach. It was developed in the early 2000s and is FDA approved for the resection of benign tumors as well as T1, T2, early stage malignant tumors in the oral cavity, oropharynx, and larynx. On the right is an example of what a patient undergoes when they have a robotic resection of an oropharyngeal tumor. Using a special retractor, the tumor can be exposed transorally, and the surgeon uses those 2 robotic arms to orient toward the oropharynx and then moves the high-definition camera in. To operate, surgeons seated in an independent console, and an assistant remains at the bedside to suction and retract while the tumor is excised. This is what the surgeon sees in the 3D view from the console, from which the camera and the robotic instruments are controlled. The major benefit of doing robotic-assisted surgery is that we don't have to open the facial skeleton to get back to the oropharynx. No lip split, no cutting of the jaw. These procedures tend to be shorter and result in less time under general anesthesia. Far fewer patients need tracheostomy following TORS surgery, and their length of hospital stay is also much shorter. They generally return to an oral diet much earlier, and there is much less incidence of long-term dependence on feeding tube. All of these factors decrease morbidity and decrease the cost of care. Here's an example of the typical presentation of an oropharyngeal tumor. This was a 49-year-old non-smoker who complained only of a neck mass for several weeks, as well as some fullness in his right ear. He had no pain and he had no trouble swallowing. And on CT scan, we were only able to see a slightly asymmetric fullness to the base of his right tongue. When followed up with a PET scan, however, there was FDG avidity, or brightness, in a base of tongue lesion on the right, as well as in that neck mass. He elected to undergo surgical treatment and had a right base of tongue or lingual tonsil resection, as well as a right neck dissection. He was staged at T2 N1 and received no further treatment. At 5 days post-op, he was able to tolerate a full diet, and he was out of the hospital in under a week. Once we've removed the cancer, the task remains to restore these patients to exceptional functional and cosmesis. Post-ablative defects frequently involve parts of the tongue, mandible, teeth, palate, and buccal mucosa, as well as the lips and chin, and they disrupt the ability to eat, drink, chew, and swallow. Historically, smaller defects that could not be closed primarily were left open to heal by secondary intent or covered with skin grafts, as options for larger reconstructive efforts were limited to local flaps or larger, cumbersome muscle flaps, usually using muscle from the pectoralis in the chest or the latissimus in the back. Neither of these options was functional nor cosmetically appealing. So the advent and now common use of microvascular free tissue transfer has greatly improved the functional outcomes of ablative tumor surgery in the oral cavity and oropharynx. We can now transfer free grafts containing skin, muscle, fascia, and bone from distant anatomic sites that allows for a more faithful restoration of form and function. One of the most basic principles of this reconstruction is to fill the ablative defect with tissue displaying similar properties. Replace like with like, as the saying goes, and the varied textures of function of the tissues of the head and neck require careful planning when choosing a donor site. The concept of the reconstructive ladder was developed with the advent of microvascular flap surgery, and it describes the vast variety of options as rungs of a ladder to be considered in an ascending fashion, with the simplest options often to be considered first down at the bottom, moving up the ladder toward the more complex options at the top. This was originally conceived to simplify wound closure. It's now best thought of as a decision-making tool, advocating for the simplest technique that will achieve optimal form and function. With regard to tongue reconstruction, current standards are to optimize residual tongue function with pliable soft tissue flaps that replace volume without compromising movement. The aim is to minimize the impact of resection on the crucial functions of speech and the oral and pharyngeal phases of swallowing. Small defects, generally located along the lateral border of the oral tongue, can be treated conservatively with primary closure when there is sufficient tissue, or to avoid restriction of movement with sewing down to the floor mouth. Wounds can be left open to heal by secondary intent, and they will eventually granulate in, as seen in the middle image. Split thickness skin grafts can also be applied. This is helpful to expedite healing, especially when radiation is expected, as long as there's sufficient tongue bulk to allow safe swallowing. With hemiglossectomy defects that involve the tip of tongue or the base of tongue, use of a vascularized flea flap is recommended for notably improved outcomes. The primary benefits are the minimization of tethering of the tongue to the floor mouth, which preserves mobility and improves speech. Secondly, the flap provides bulk. Reconstructed tongues are static, and they require bulky tissue to allow the upper surface of the neotongue to contact the palate during swallowing. Most common donor sites for tongue reconstruction are the radial forearm and the anterolateral thigh, the choice of which should be matched to the defect with consideration of the desired function. For instance, using overly bulky flaps from the thigh to obliterate small defects, or too thin of a flap from the forearm for a large combined defect of the oral tongue and the base of tongue, may get the wound closed, but will result in poor speech and swallowing outcomes for the patient. The radial forearm free flap is the most frequently used microvascular flap in the head and neck. It's long been considered a workhorse since its inception in the 80s. It's based on the radial artery, and nearly all patients or candidates, provided adequate collateral flow through the ulnar artery, can be demonstrated pre-op so as not to leave the hand ischemic. Its advantages are it produces a thin, pliable flap that replicates the mucosal lining well. It's easy and quick to raise, and it can be harvested with a vascular pedicle that's long enough to reach donor vessels anywhere in the neck. It can be taken with a segment of radius bone for defects in need of bony reconstruction, and the disadvantages are few. Aside from an unsightly scar, patients rarely complain of anything but maybe some decreased sensation over the lateral forearm, and they return to function fairly quickly after surgery. A radial forearm was used to reconstruct the tongue in our previous patient seen with the T4A tumor. Following resection, the defect was about 75% of her oral tongue and included the tip. An 8 by 6 centimeter forearm flap was used to restore bulk to the right tongue. And following surgery, she was tolerating liquids by mouth without aspiration or nasal regurg at 7 days post-op. She was able to tolerate solids at 10 days post-op. Regarding speech, at 9 months, her speech pathologist noted that she was more than 75% intelligible in normal conversation, and she was satisfied with the cosmetic appearance. Alternatively, Flaps from the anterolateral thigh, which are based on a branch of the lateral circumflex artery, which descends on the outside of the thigh. The advantages of this flap are its very low morbidity, resulting in little more than a vertical scar on the outside of the patient's thigh. It can be harvested simultaneously. Two teams working together, one resecting the tumor and one raising the flap, can reduce the surgical time when this flap is used. And it offers a large volume of soft tissue comprised of skin, muscle, and fascia, which can be put together in various ways depending upon how you harvest it, to account for fasciocutaneous flaps, which leave skin out of the mouth, myocutaneous flaps, which help add bulk to tongues that are in need of support, and adipofascial flaps, which help line mandibular defects without the added bulk. The disadvantages are that there can be some significant anatomic variation, which requires you to slow down and can sometimes render a flap unusable before it's been raised. Other than that, in an obese patient, thigh flaps can be somewhat bulky, and in flaps that need to go inside the mouth, persistent hair growth is unavoidable and often bothersome to patients. This is another patient with a larger T4A tumor. Following resection, the defect was about 50% the width of the oral tongue as well as the base of tongue. So the decision was made to use a larger size, 12 by 8 centimeter flap from the thigh. Given the size, this patient was unable to tolerate liquids without aspiration for about 2 weeks post-op, probably also attributable to the decreased sensation at the back of the throat due to the base of tongue defect. But by 2 weeks, he was able to tolerate a pureed diet and most solids at 6 months. Regarding speech, he did a little worse. He was about 50% intelligible for the first 6 months, but about a year later, he underwent some atrophy and improved marginally to about 75% due to a little bit more movement for his tongue. Regarding the mandible, segmental defects are best reconstructed with bony microvascular flaps to restore continuity. Alternate approaches that have historically been done include free bone grafts, which are subject to resorption, infection, and necrosis. Alternatively, reconstruction plates covered with soft tissue from local muscle flaps have been used, but they tend to develop fistulas at a high rate and are prone to fracture. The most commonly used donor sites for bony flaps are the fibula, which is generally the workhorse for bony reconstruction in the head and neck, as well as the scapula, iliac crest, and as we said, osteocutaneous radial forearm. The fibula is the first choice, especially for extensive mandible defects. It's based on the peroneal artery, branches from the posterior tibial artery just below the knee, and is long enough that it can reach most vessels in the neck for reconstruction of the maxilla and mandible. The possibility of the presence of anatomic variants, as well as peripheral vascular disease, mandate that pre-op imaging with CT angiogram be obtained to ensure adequate vascular supply to the foot following harvest, as well as healthy patient vessels. Its advantages are a long segmented durable bone stock. It's capable of reconstructing nearly the entire mandible when necessary, and it has the ability to accommodate osseointegrated implants for restoration of dentition. Like the thigh, its location distant from the primary site allows for shorter surgeries when two teams are used. Disadvantages are the possibility of ankle instability, which needs to be considered in older and less mobile patients, as well as a smaller skin panel that's frequently mismatched in color to the tissues it's going to replace up in the face and mouth. An example of which is this T4A tumor that comprised almost 11 centimeters of the right mandible, including the symphysis, body, and angle. Intraorally, a flap of gingiva, floor, mouth, and buccal mucosa was also resected. To reconstruct this patient, that 11 centimeters of bone was easily restored through the use of a fibula. An 8 centimeter skin paddle completed the oral reconstruction. After 7 days, this patient was able to tolerate a PO diet without aspiration, and she was 100% intelligible. The scapular free flap is less commonly used, but it can be invaluable in restoring some of the more complex defects in the head and neck. The thick bone stock at the lateral border of the scapula, as seen up top, can be used to reconstruct bony defects of up to 10 centimeters in most patients. It's based on the circumflex scapular artery and provides branches to skin, bone, and muscle, all of which can be raised independently, as you see in the bottom image. The vascular system allows for harvest of a wide amount of muscle, soft tissue, and bone in a single flap that can reconstruct large three-dimensional defects. Additionally, the vascular pedicle is largely spared from atherosclerotic disease and is an excellent alternative in patients who are not candidates for fibula flaps due to vascular disease. The disadvantages are that the harvest requires the patient to be repositioned intraoperatively, which prolongs their time on the table, and it can preclude the two-team approach. Also, in most patients, the scapula bone is unsuitable for dental implants. Here's an example of a patient who benefited from the use following an extensive ablation to reconstruct a multi-surface defect with a single graft. The defect, in addition to a 5-centimeter mandibular segment, included large swaths of the alveolar mucosa in the mouth and the cervical skin externally. A flap was harvested that included a length of scapular bone, along with 2 separate skin islands to restore the internal and external defects. We were also able to include a flap of muscle from the latissimus dorsi to restore the contour of the neck. Within a month, this patient was eating and speaking intelligibly. We now have the ability to create surgical models and digital treatment plans prior to entering the OR using virtual surgical planning. The use of computer-assisted planning based on patients' preoperative imaging has made individual custom plates and cutting guides common in head and neck reconstruction, and it has enhanced the cosmetic and functional results that we can achieve. This is especially useful in patients with bulky jaw tumors that distort the surface of the bone and don't allow for intra-op contouring of a traditional plate, which historically has resulted in less than ideal outcomes. The additional benefits are enhanced bony contact, which optimizes healing and reduces operative times. With virtual surgical planning, reduced technical expertise and experience is required to perform these procedures, and it's been shown to produce more predictable aesthetic and functional results. So let's look at one final patient whose cancer journey illustrates a lot of tonight's talking points and who benefited both from the interdisciplinary cooperation and management, as well as virtual surgical planning that led to a successful outcome. This was a 34-year-old male. He was a non-smoker who complained of a painful ulcer over his right posterior molar in the area of the retromolar triangle. He noted that the pain was exacerbated when he ate hot things and spicy things. And he presented to his dentist, who first treated him with a course of antibiotics out of concern for an abscess. When he returned, the tooth appeared to be unhealthy, and he underwent an extraction. About a month afterward, the site continued to be painful and wasn't healing. So he was referred to an oral surgeon who performed a biopsy, which returned oral squamous cell carcinoma. He was ordered a CT scan, which showed only subtle enhancement at the right retromolar trigone and a 3-centimeter lesion, but did show some erosion of the tooth sockets around the 3rd and 2nd mandibular molars. On PET scan, he was noted to have multiple cervical nodes, as well as some radiotracer uptake in that right retromolar trigone. He was notably upset, given his young age and otherwise healthy status, at the extent of surgery that we were going to have to put him through, as we recommended a segmental mandibulectomy and reconstruction with a fibula-free flap. So we plotted him out a virtual surgical plan, which gave him a custom plate that was conformed to the exact specimens of his mandible based upon preoperative CT scan. We also had cutting guides made, which ensured that the bone would fit. He underwent a segmental mandibulectomy, a radical neck dissection via the visor approach, and we placed that fibula-free flap without incident. He underwent chemoradiotherapy, given the bony invasion. He did quite well. 1 week following surgery, he lost his tracheostomy and was able to eat. And he's pictured here at 3 months, at which point he had returned to work and was tolerating exercise with no limit. 1 year post-op, he was tolerating a full diet, and he had no evidence of disease on follow-up scan. And at 2 years, surveillance scan showed no evidence of disease and complete osteosynthesis of his neomandible. He had undergone implants and completely restored his dentition, getting back to a fully functional life, despite what otherwise could have been a devastating diagnosis. Regarding postoperative care, these patients are generally recommended to be followed every 3 to 4 months for the first 2 years out from surgery, and after that, every 6 months until 5 years. After 5 years, at which point they're considered cured, they should still be seen annually. While most recurrences usually occur in the first 2 years, long-term recurrence has been shown to occur, and these patients should really never be lost to follow-up. So cancers are not always obvious, and routine head and neck exams are quick, inexpensive methods of increasing detection. So in closing, lesions that hang out for longer than 2 weeks should be addressed promptly. Incisional biopsies are safer than excisional biopsies. It's important to distinguish tumors in the oral cavity from the oropharynx for purposes of diagnosis, and hopefully in the near future, modified treatment. And finally, early recognition is key. The greatest improvement in head and neck cancer survival will be seen as patients and practitioners become more aware of the signs, symptoms, and risk factors that are associated with head and neck cancer, and increasingly we make the diagnosis at an early stage. Thank you, everyone, for listening. If there are any questions, I'm happy to take them.
Thank you so much, Dr. Hamilton, for sharing your insights and expertise on this area. And we do have a few questions for you tonight. So our first question is from Jolene, and they ask, I'm just curious on what your thoughts are about Veloscope/oral ID cancer screening tools. Do you have any insights on if those are useful?
They can be. We don't use a lot of them in head and neck and otolaryngology. I think most of the folks on this webinar probably have more experience with the direct use of it. We read about them to see how effectively they diagnose disease. And what I've seen is that most of them will pick up disease. They're pretty sensitive, but the specificity is fairly low. They have a hard time distinguishing between dysplasia and not dysplasia. So I think their role, and what I've seen in the literature, is that the role is to identify candidates who need to be biopsied, especially in lesions which have medium suspicion. If you've been following somebody for something that doesn't look right and it lights up under Visilight, it's a motivation for pushing them toward an incisional biopsy to get a definitive pathologic diagnosis.
All right, thank you. Our next question is from Richard, and this is, he's asking what types of images were shown it was in the slide prior to the PET scan slide on the imaging. So it was kind of way back in the presentation. Do you remember what you used to take those images?
An MRI.
Okay.
Magnetic resonance imaging. They're complementary. CT scans can give us most of the detail we need, and they're widely available, and it's quicker to get a patient a CT scan, which makes for quicker clinical staging. But in patients with disease, particularly those who show any sort of cranial neuropathies or have deep soft tissue invasion, I'll always get an MRI to distinguish the extent of the tumor, to see how far. It'll give us a better idea of how extensive the resection has to be, which lets us know, how much reconstruction we can expect to have.
Okay, thank you. Our next question asks, and I apologize if I pronounce this wrong, but are pemphigoid lesions precancer?
They can be. They need to be watched.
Okay.
I don't have a lot of experience with patients with pemphigus, but I have read that squamous cell cancers, because of the chronic irritation, can develop in those lesions.
All right, thank you. And I think that wraps up our Q&A for tonight. So thank you to everyone who asked questions to Dr. Hamilton and participated in tonight's webinar. And Dr. Hamilton, thank you so much once again for sharing your time with us tonight. And thank you to everyone who attended. You will receive an email in the next week with the recording of tonight's webinar. If you do have any questions, please reach out to webinars@henryschein.com and we'd be happy to get an answer for you. Have a great night, everyone. Thank you, Dr. Hamilton.
Thank you all. And feel free to share my email if anybody has any specific questions. I'd be happy to take them.
Absolutely. Thank you so much. Have a great night.
Take care.